Hello, doctors. Today we are going to study an important topic, that is ovarian cyst. It is very common, commonly found in the reproductive age women, often discovered incidentally and on ultrasound. But sometimes it may present with the pain, mass, or menstrual irregularities. So let's understand its types, presentation, how we can diagnose the condition, and management, and so on. Let's move forward with the topic. Talking about the definition, ovarian cysts are fluid filled sacs within or on the surface of an ovary. It can be physiological, or pathological. Physiological as a part of the normal menstrual cycle, or pathological due to neoplastic changes. Our main job is to differentiate benign cyst from the malignant ones, and physiological from pathological. So most are benign and functional, and we have to resolve it spontaneously, and some may be requiring a neoplastic and require surgical intervention also. So we have to always differentiate the benign cyst from the malignant cyst, and also it is very important to differentiate from the physiological or pathological, physiological from the pathological. So that's the definition, or the brief intro about what is an ovarian cyst. Moving on to the classification of ovarian cyst. We often classify ovarian cyst broadly into two groups: functional, and that is physiological, and this neoplastic, or the pathological. So functional, it can be like benign, neoplastic, and malignant also. Functional cysts are hormonally driven and often self-limiting. So it contains this follicular cyst, corpus luteum cyst, or theca lutein cyst, and all. Then there is one more thing is benign neoplastic. Under benign in pathological have two types: neoplastic, that is benign neoplastic. In under this we'll be seeing serous cystodenema, dermoid mucinous cystodenema, dermoid cyst, that is mature teratoma, endometriotic cyst, and so the that is the pathological benign neoplastic things. And the last one is malignant cyst. So malignant cyst, under this we'll be seeing serous cystadenocarcinoma or mucinous cystadenocarcinoma. So you can say pathological all under the pathological, but it's kind of, you can differentiate into like a third type of ovarian cyst. So functional, pathological, and malignant cyst. So malignant cyst you can categorize into a third type of ovarian cyst, which is carcinoma type, like serous cystadenocarcinoma and mucinous cystadenocarcinoma. So these are the different classification of ovarian cyst. Moving on to the uh, etiopathogenesis. So etiopathogenesis, as you can see, as a functional cyst which results from the normal ovulatory function. This may be due to any hormonal or genetic factors, or then hormone imbalance, which because of the excess FSH or LH, which may contribute. Then next one is the neoplastic cyst, which develops from the ovarian epithelium, germ cells, or stromal tissue. That is another type of thing. And what are the risk factors you can say is, because if it is nulliparity in case of early menarche, or it is in case of late menopause, and family history of ovarian cancer, in such cases, these are the risk factors. When talking about the functional cyst, like we have mentioned follicular, corpus luteum, and theca lutein cyst. So these are most common and mostly harmless cyst, functional cyst. So a follicular cyst, under that, which we have discussed in before previous slide. Functional cyst have three types: follicular, corpus, and theca lutein. So follicular cyst forms when the follicle doesn't rupture. So these are usually small and resolve spontaneously. Corpus luteum cyst will form after the ovulation and can rupture or cause any mild pain. Theca lutein cysts are usually bilateral and is associated with the high HCG conditions like a molar pregnancy. So that is about the functional type. When talking about the benign neoplastic cysts, which we have discussed, so these are the most common surgical entities like serous cystoadenoma is usually a simple and unilateral mucinous cyst which are large and multilocular. Next, the dermoid cyst, which are mature teratomas, which are seen in the younger women. Classic ultrasound finding is in this due to is echogenic shadow due to hair and teeth. Next is the endometriotic cyst, which contains a altered blood, giving that we can say like a chocolate appearance. So that is kind of a neoplastic or pathological classification of ovarian cycle. Then talking about the malignant cyst, which we have discussed, when we see a cyst with a thick septations, papillary projections, or solid areas, we must think of malignancy. So most ovarian cancers arise from the epithelial origin. So always correlate with the age, ultrasound findings, and tumor markers like CA125 and all. So also you should be aware about the risk factors also. So these can be because of the hormonal genetic factors or any of the chronic anovulation in PCOS, that is also can predispose to cyst formation. And if there is any family history and nulliparity, so while treating the ovarian cyst, you should be aware of all the type of classification, what are the different types of ovarian cyst, whether it is malignant, pathological, neoplastics, benign and all. Then also you have to be aware of the risk factors too. Next, so as I have mentioned here, functional, whether the physiological cyst. We have discussed now what about the follicular cyst, corpus luteum cyst, and theca lutein cyst. So these are the different types, and we have mentioned what are all the types and how it is. And there is also a differentiation. You can see follicular cyst will be less than 5 centimeter usually, and it will be unilateral and asymptomatic. Corpus luteum cyst may cause a delayed menstruation or pain, and theca lutein cyst due to the high HCG level. So, as we have mentioned, which will be seen in the molar pregnancy. So, you should be able to differentiate all the type of ovarian cyst is not common for everyone. Like it will not be same for everyone. It can there be certain differences in each type of ovarian cyst. So you should be aware, you should be able to identify and differentiate it from the physiological and the pathological cyst. So pathological also we have discussed the serous cystoadenoma and how it is present, mucinous cystoadenoma, dermoid cyst, endometriotic cyst, that is we can call this as a chocolate cyst also due to endometriosis, and the malignant cyst, which is irregular walls, solid areas, papillary projections. So these are all things we have discussed now. Moving on to the clinical features. So clinical features, and before that you should be aware about the pathophysiology also. So repeated ovulation can cause small injuries to the ovarian surface. So when epithelial cells get trapped, cyst may form. So hormone imbalance, especially high estrogen, which will support the cyst growth. So over time what will happen, some benign cyst can undergo neoplastic change, so that can lead to a pathological ovarian cyst. So that is how the pathophysiology works in the ovarian cyst. Now coming to the clinical features. So most ovarian cysts are discovered incidentally. However, large cysts cause a dull lower abdominal pain or heaviness or any kind of menstrual irregularities, and there will be pressure symptoms like frequency of urine, constipation and all. If the cyst ruptures or undergoes any kind of torsion, there will be a pain which will be sudden and severe pain. So that can be that is kind of an emergency case. So that is also you should be knowing. And infertility in endometriotic cyst also present. So usually many times the patients may don't have, they will not present with any symptoms. Many cases are asymptomatic, and sometimes found incidentally also. But there are few other things, few other patients who may have these kind of clinical features, like most importantly menstrual irregularities, lower abdominal pain and heaviness, pressure symptoms, acute pain if rupture. And so the acute once the cyst rupture, that can goes to an emergency case, so you have to treat accordingly. So these are the clinical features of ovarian cyst. Moving on to the clinical signs. So what are the signs you will be seeing in this condition? The signs are that the ovarian cyst will be smooth, cystic, mobile, non-tender mass in the fornix or adnexa. It is usually separate from the uterus. So in malignant cyst condition, there will be irregular nodular fixed mass with ascites. So that will be the presentation in the malignant type of ovarian cyst. So you should, that is important. So that is why I'm telling you should be able to differentiate each and everything from the benign from the malignant, physiological from pathological. So that is the key, what to tell, key important point, key tip for you to differentiate ovarian cyst. So you should be very thorough about the clinical features, the types of ovarian cyst too. So clinical signs, you can differentiate in malignant cyst. You can see such irregular nodular fixed masses with the presentation of ascites, and other clinical signs are smooth, cystic, sometimes mobile, non-tender mass will be present in the fornix or adnexa. Usually it will be separate from the uterus. So these are the clinical signs of ovarian cyst. Moving on to the complications. So the most feared complication is torsion, and which the ovarian or the ovary twist on its pedicle, causing ischemia and acute abdomen pain and acute vomiting, such conditions. So torsion is one of the most important feared complication you will be seeing in the ovarian cyst condition. Next is rupture. So rupture can cause intraperitoneal bleeding, like shock, and hemoperitoneum as a intraperitoneal bleeding and pain with shock, and hemorrhage can happen, sudden pain with tenderness, and then there can be infection also. Rarely, the benign cyst can have a tendency to transform into malignancy. So, malignant transformation, which is rare in kind of dermoid cyst and endometriotic cyst, such cyst, there are rare chances that this benign cyst can transform into malignant cyst. So, that is the complications you should be knowing. Next comes the investigations. So investigations, what and all thing we have to do to diagnose the condition. First thing, ultrasound. So USG is kind of like we can say our best from here. So it tells us what is the size of the ovarian cyst, the wall thickness, internal echoes, if there is any septations or not, or any kind of solid components. So we can, so with the help of USG we can differentiate the cystic from the solid mass. So that is what the important point here. Then you can do Doppler study, vascularity and malignancy risk. Then you can also do tumor markers like CA125 and all, which will help when malignancy is suspected, though not specific, but you can do that. Then always rule out for pregnancy with doing a beta HCG. Then next thing you can go for CT, MRI for any kind of complex or large cyst. Then you can do diagnostic laparoscopy for like if you have an unclear diagnosis or treatment, then you can go for a diagnostic laparoscopy. So talking about the USG in ultrasound, what you will see, like in ultrasound you can see small cyst which will appear thin walled and anechoic. So if you see internal echoes or septations, think for hemorrhagic or endometriotic cyst. Solid areas or increased vascularity on Doppler should always raise a red flags. So that is an important point here. investigations, under the USG findings, you can see these things. Next is the differential diagnosis. So differential diagnosis, you have to always keep these differentials in mind, especially in the reproductive age women presenting with pain and adnexal mass. Ultrasound, as we have mentioned, ultrasound will help to differentiate cystic from the solid lesions. So the differential diagnoses are hydrosalpinx, ectopic pregnancy, uterine fibroid, endometriosis, tubo-ovarian abscess, and all. So these things are very important. Next is the management. So how you have to plan the treatment and how you have to do it. So management depends on certain criterias, on age, cyst type, and symptoms, and the menopausal status of the patient, and symptoms and complications, or symptomatic or large cyst need intervention. So the size and appearance of cyst is very important, as well as the symptoms and complications. And serum tumor markers, desire for the fertility, and all also a criteria. So based on this criteria, you have to plan the treatment accordingly, whether you have to treat the patient on the OPD basis or the IPD basis. Talking about the OPD management, OPD management is like in the outpatient setup. If you see a small cyst, like for example functional cyst which is less than 5 centimeter, observe it and repeat the ultrasound after 6 to 8 weeks. Functional cyst often regress, so that is thing you have to do. In hormonal suppression, you can do OCPs to prevent any kind of such reoccurrence. So OCPs can suppress the ovulation and prevent any kind of new cyst. Then pain management with NSAIDs, and treat any associated conditions like endometriosis or PID and all. You have to accordingly treat the associated conditions too. And also you have to counsel the patient regarding the warning signs about the pain and rapid growth and all. So always advise the patient for a regular follow-up for the further studies. So that is the OPD management. So OPD management usually you can do to the thing, mainly functional cyst cases you can do, which is where the cyst is less than 5 centimeter. You can do an OPD management. Observe the patient, treat the symptoms properly, and treat the associated conditions accordingly, and counsel the patients regarding the signs of pain or rapid growth and all, and always ask them to follow for a follow-up. So that is how you can do an OPD management. Talking about the IPD management, there are certain things where we'll do surgical management. The surgical management we are doing in hospitalized patients, those with the large cyst, for example greater than 8 centimeter, or persistent cyst, or complex cyst, where there is torsion or rupture, or hemorrhage, or post-menopausal cyst and all. In such conditions, surgical, and where the cysts are not able to manage in through the medical therapy, then you can go for a surgical management. So in young women, we try to preserve the fertility with the cystectomy. Then in post-menopausal or suspicious cases, oophorectomy is safer. Then laparoscopy is preferred for the benign cyst, and laparotomy if malignancy, any kind of malignancy suspected, you can go for a laparotomy. So always send the specimen for histopathological confirmation. That is one of the most important point here. So this is how we will be treating the managing the condition IPD basis. Only if it is greater, not able to manage through the medical therapy, and the size is very large, you're not able to treat accordingly with the medical therapy, then you can go for a surgical management. Next are the special types of ovarian cyst, like endometriotic cyst, like medical, OCP, general, and also surgical excision we can do in such endometriotic cyst. And dermoid cyst, you can do surgical removal due to the torsion risk. Then polycystic ovaries, no, it's not a true cyst, it can be managed medically also. So that is a different ovarian cyst. And ovarian cyst in pregnancy. So pregnancy, commonly corpus luteum cyst, which regress spontaneously. There can be a cause of torsion, rupture, or obstructed labor also in pregnancy if the patient is diagnosed with ovarian cyst. Surgery you can do in second trimester if the cyst is greater than 6 centimeter or if it is symptomatic. Then you can do laparoscopic or open approach depending on the case, age, fertility, and all the other criteria. So that is the thing about ovarian cyst in pregnancy. And what are the post operative thing you can do to the patient? Monitor after the surgery, monitor the patients, monitor the vitals and urine output. You have to control the pain with the antibiotics and all NSAIDs, and early ambulation and diet progression also advising, and it should be advised. And histopathological examination of the cyst is required. Follow up with the USG for recurrence or any contralateral cyst. So these are the post-operative care you have to advise the patient. You have to do the patient to the patient. Prognosis. Talking about the prognosis, functional cysts have a good prognosis. It is self-resolving. Talking about the benign neoplastic cyst or the pathological cyst, have a good outcome after the surgery. Malignant cyst prognosing depends on the histology and the stage. So in such cases, regular follow-up is very essential. So to summarize our today's lecture, most ovarian cysts are common, are benign and self-limiting. Ultrasound is the very important diagnostic tool for diagnosing the condition. You can manage the condition conservatively if it is small and simple, like size is smaller. You can do it medical therapy. If it is large or suspicious cyst present, surgical removal is required if any malignancy. So always rule out for any such kind of malignancy, especially in the post-menopausal women. So these are the important things we have discussed in today's lecture. Hope you got idea and understood regarding the ovarian cyst topic. So that's all about ovarian cyst. It is very simple to understand, but clinically is very important to differentiate from the benign from malignant, and physiological from pathology, and to decide who needs surgery and who can be safely observed. So thank you doctors for patient listening. Have a nice day. Thank you.